So good morning, and my name is Cheryl Turner, and I am the Director of Global Education and Training for Legion Healthcare Partners. But I want to thank Annabelle and DYN'R and for again presenting a webinar for the dosimetry profession for radiation therapists or radiation oncologists who might be on here, physicists, to help us better understand the SDX system and motion management when we're planning those things for patient treatment. So I want to thank Annabelle again. I want to thank Julie and Sina for being part of this webinar. And Annabelle, I'm going to let you continue with introductions about DYN'R and the SDX system, and then to introduce Julie and Sina.
Yes, thank you very much, Cheryl. Welcome, everyone. Welcome to our webinar today. So our speakers today will be Julie Moreau. She's a senior dosimetrist at New York Proton Center. And we also have Sina Mossahebi. He's assistant professor at the University of Maryland School of Medicine, and he's working at the Maryland Proton Treatment Center. So today they will speak about the clinical implementation and treatment planning experience using the SDX system. We are very happy to have more educational material for dosimetrists and treatment planning today. So I will leave the mic to Sina now. And again, thank you very much, Cheryl. Thank you, Legion, and happy to be here.
I did want to add real quick before we get started, Annabelle and I will be monitoring the Q&A box. So if you have a question, if you've got a comment, something that you'd like to say to the presenters, just type that into that question and answer box, and Annabelle and I will monitor that throughout the process, throughout the presentation. So thanks a bunch, and we'll let you take it away, Julie and Sina.
Okay. Hi, everyone. I'm Julie. As Annabelle said, I work at the New York Proton Center as a dosimetrist, and we're very excited to give a talk about our clinical experience using SDX in both New York Proton Center and Maryland Proton Center, and we hope you get a lot out of it.
Welcome, everyone. I'm going to start with, let's see. So we have nothing to disclose. We just invited by DYN'R to give this presentation. This is the outline of our talk. I'm going to start with the introduction, and I'll talk about the motion management and specifically talking about the spirometry system, and then focus on the SDX system and how we use it and the room setup we have with the Pro-Beam system.
And then I'll move into part one of the talk, which is an overview of the clinical workflow and how to use SDX breath hold treatment, taking you from the start of bringing a patient into the clinic, preparing them for using the SDX system, getting that initial sim, and then do a little touch on the treatment planning and the image guidance and treatment procedures when you have a breath hold patient. And then once that is done, I'll move forward to part two, which is a deep dive into the clinical experience of planning experience that we have, what I've experienced and what Sina has done at MPTC. We'll go into contouring, beam selection, and collision checks, plan parameter selection, continuous monitoring, and some clinical examples.
And then the last part, I'm going to talk about the dosimetric evaluation of the breath hold plans. So I'll look at the breath hold versus non-breath hold plans and look at some data from the patient. And at the end, I'll look at the QACT and reproducibility of the breath hold plans. For motion management, typically we use external breathing metrics, and they're useful for predicting tumor motion, reducing respiratory motion uncertainty, and basically reducing the dose cloud to cover the target. And then by doing that, you can spread organ at risk. Breath hold technique is one of the motion management system or methods that it can mitigate the motion of the target, and also minimize the target margin and improve normal tissue sparing. In general, there are two different methods. One is a non-spirometric or external surrogate, and then the other one is spirometric, which is the internal volumetric airflow. For the non-spirometric, we have the surface imaging like Vision RT or RPM system from Varian, And for the spirometric system, we have the ABC system from Electo and also SDX from DYN'R. Looking at the non-spirometric system, there are some advantages and some disadvantages. First of all, is the clinically is feasible. You can reduce tumor motion and also spare the organ at risk. It has some of the system they have audio-visual feedback that improves the reproducibility of the plant delivery. It has a gated treatment delivery and is a good surrogate for the internal respiratory motion, and it's comfortable for patient. The disadvantage is still the external surrogate is not related to the, it's kind of related to internal, but it's not getting, exactly directly information from internal motion. It gives you 1D or 2D information based on the surface, or if you have an RPM system, it's almost 1D information. The gating module is not compatible for all the treatment delivery system, and some of the system, they don't have the audio-visual feedback. And especially for proton centers, because of the SNOT and clearance that we have, it's not really practical in some of the cases. And also for like some system like RPM, when the block position is important, so it's kind of like depends on the position, so you may get a different signal. For a spirometric system, the advantage is the same as the non-spirometric system, is feasible for the using the for breath hold and do the motion management. Gives you audio-visual feedback, which improves the reproducibility. Similarly, it has a gated treatment delivery and is a more accurate surrogate for internal respiratory motion and easily portable. So you can move it from one room to the other room. The disadvantages are the drift in the signal. So that's why we need to do QA daily to check the calibration. It's uncomfortable for patient, so it's not similar to RPM or Vision RT that patient doesn't feel anything. This one patient has to breathe through the mouthpiece, and this gating module is not compatible for all the treatment delivery system, and it still is a surrogate. It's not actual tumor tracking. What we have at NPTC and similarly Julie's team at the NYPC, we have an SDX system from DYN'R. It's a voluntary breath hold technique. So it has a different component. It has a air flow tube, and there's a filter that has a mouthpiece and then nose clip and then with your goggles. So basically patient breathe through this mouthpiece, and then the signal goes to the SDX system, and patient can see the breathing pattern in the goggle. For the connection with the probeam system, so what we have from SDX, we have the SDX system inside the room, we have the SDX computer outside the room, and the gating module outside the room. So we have the patient, and then we have the SDX system. The patient can breathe through the SDX system, and then through the Ethernet cable, the signal goes to the computer outside in the control room, and which is connected to the gating module of SDX, which is connected to the probeam system gating module. And then it can get sends a signal to the probeam system to control the beam.
Okay, so we'll move on to part one of the talk, talking about the SDX treatment process, taking you from a patient from the beginning of coming into the clinic all the way through treatment. And so the first step is to have the patient practice. Breath hold, and doing a breath hold and holding it for a long time can be difficult at first, but it definitely improves over time. So practice makes perfect, definitely in this scenario. So the first day the patient comes in, the therapy team will take some time and prepare the patient for actually using the SDX device, to explaining to them how to breathe in and how to hold the breath through the spirometer and how to use the goggles, basically take them through A to Z of using the SDX machine and explaining how it's going to help their treatment. And then once we get into the CT imaging room, we need to set the breath hold level. So taking in that very deep breath hold and holding it for a long time is not very comfortable. So we want to set it to a threshold around 75 to 80% so that the patient can actually reproduce it every day. So how we get there is the patient will take 3 to 5 very deep inspiration breath holds. And you can see in this image here, you have test 1, test 2, and test 3. And once that is done, we will then go ahead and take an average of those test breaths and reduce the value down to 75 to 80% and establish a treatment planning threshold. So this is the bar that we're going to set so that the patient will attempt to reach it and go ahead and deliver the treatment at that threshold. We want to make sure it's reproducible and it's comfortable for the patient and that the patient can get to that every single time they come in for treatment. So once we have established this threshold, the patient's going to go ahead and get that CT simulation at the SDX breath hold using the SDX. So we'll go ahead and run the patient through the CT scanner at that threshold. In addition, we also can sometimes do a comparison to a free breathing scan or get a 4D CT for a particular patient, which can be used for backup or just comparison purposes. So once we get this initial, so actually going through getting the initial simulation, it's a manual process. The CT scan will be taken when the patient is holding that pre-established breath hold level. If a patient goes out of that breath hold, the therapist needs to stop the imaging manually. Typically, it's recommended to scan above the goggles all the way through the target area and the surrounding anatomy as specified by the physician. You just want to get all the information that you can of where the patient is relative to the SDX device, and then obviously get the target information as well. In addition to normal planning field of view, which in our clinics, it's typically 500 to 650 millimeters field of view, we can also get a reconstructed one at larger, so you can get more CT information about that SDX device. And so then we would, once the SDX treatment planning CT is acquired, you would go ahead and either get the 4D CT that you need for the particular patient or free breathing scan for comparison or backup. For breast setups, we do want to turn the chin to the contralateral side along with the SDX components. It's pretty similar to what you would see in the Proton clinic. So you can see here the patient, we're treating the left side breast. So the chin is pulled over to the right along with the SDX device. It's on an angle now. And then for neck and mediastinum patients at both our clinics, we actually use a boss frame and a mask system. And there's no place really to put the SDX device. It's kind of a free air over there. So you have to think about how you're going to do it. And so this is a picture from MPTC. They made a in-house structure to put the SDX device, and NYPC has also done something similar for these patients. Okay, so now that we've gone through and we have our scans, whether it's an SDX scan and a 4D CT or free breathing, we go ahead and take the patient through a treatment planning process. You can, depending on your clinic needs and your clinic procedures, you would either plan them at the same time before the patient comes in or have it available for maybe doing a replan down the road. And then once everything is done, the physician will go ahead and do a plan evaluation of those plans. Okay, so then what we do is once everything is said and done, the patient will go ahead and come through to get their treatment on their treatment day. Okay, I see there's a question about open face mask. When you use the SDX device, you do need to make an opening for the devices. Okay, so the patient's going to come in for their treatment day and get some image-guided radiation therapy in order to set them up for their actual treatment. And so this image guidance is done at the breath hold. And in order to get a CBCT, the patient has to hold their breath for at least 30 to 35 seconds. And once the treatment is going to go ahead and get started, there's an automatic gating module that's actively connected to the ProBeam system that will allow for seamless delivery of the SDX plan. Okay, so a little more about this. So for the IGRT, it's a manual process. So when you're getting the KVs and CBCT, the therapy team will watch the patient go up into that threshold for their breath hold that was established at the time of CT SIM and make sure that they're getting the imaging at that. But for treatment, it's automatically connected. So it's called automatic gating module, and it immediately stops the beam once the patient exits their breath hold threshold. And then when the patient's ready to go back up into that threshold, it'll resume treatment from there. So once the patient is on treatment, we're always double checking everything and doing quality assurance. We want to make sure that we are monitoring these patients and making sure that that breath hold is delivering the plan at the level that we had originally planned for the patient through weekly QACTs and evaluations. Things that can happen, you might see tumor respond, you might see anatomical changes. So we want to make sure we incorporate that in the treatment process. Okay, so this is a really nice graphic that kind of talked about. So bringing the patient into the clinic is the first step in identifying them as a breath hold candidate. So then once that happens, the physician and the physicist would then go ahead and evaluate whether or not the patient is a candidate. And then whether or not they're going to use breath hold, there's two tracks. So towards the right is yes, and taking the patient through what the process that we just described. And at any point in time, you can always move to not treating the patient breath hold as long as you have the scans and the contours done on those scans to support treating the patient non-breath hold. But the process is pretty straightforward. You just want to make sure that the patient is a good candidate and able to hold that breath, and you're ready to modify as needed and cater to that patient's particular abilities and tumor areas. So who do we treat? So at New York Proton Center, we've done roughly 97 patients treated with SDX treatment, and the majority of it is actually breast and chest wall, so about half. And then a third of it is liver cases, and then a little less than that is lung and mediastinum, and just a handful of pancreas and heart. Of these patients, 61% is conventional fractionation, which is under 2 gray or 2 gray or under. And then we also have a pretty good subset of 20% that's hypofractionated, so greater than 2 gray per fraction, and a pretty good set as well that's SBRT, which is 8 gray to 12 gray per fraction. The SBRT cases are really important subset of patients to use with SDX breath hold, because if you have a lot of motion, protons are really, really sensitive to any motion that happens on the machine or within the patient as they're breathing. So if we can minimize that, and for something that's like on the diaphragm, if we can really stop the motion completely, that's going to be better for the patient overall. So for that subset of patients, it's really, really important we have this available for them.
At MPTC, we had the referral for SDX treatment, about 200 patients. From those, 168 patients underwent SDX stimulation, and we treated 160 patients. We started in March 2018, so it's almost 4 years, and then we treated 160 patients. And most of the cases we had, it was liver and lung and mediastinum. And we had some cases of pancreas, abdomen, esophagus, and others like kidneys. Regarding fractionation, most of them were hypofractionated region, and we had 42% conventional. From the hypofractionation, most of them we had like 2 to 4 gray. We had some SBRT cases, and then we had 2 grade patients with a 15 gray fraction. In summary of the part 1, so we can use this system for any moving tumor if the motion is regarding the breathing, and the patient should be able to hold the breath at least 30 seconds. That's kind of the limitation of the probing, because if you want to have a CBC, the time takes to do the half kind of arc CBCT takes about 30 to 35 seconds. The smaller the target, is easier to implement this procedure. So usually you want to limit the number of fields and then time of delivery of each field. So if you have less than 2 minutes per field and like 3 to 4 fields, that's kind of feasible. And it's good to ask patients to practice breath hold before coming for the simulation and also before the initial treatment. For image guidance, we use KV and CBCT. So for CBCT, we use full fan, and it's a small field of view. And that's why we need to have at least breath hold of 30 to 35 seconds. And to evaluate and monitor the treatment, we use a weekly QACT to look at the tumor response and any change in the anatomy.
Okay, so now moving on to part 2, a deep dive into treatment planning. So the first thing you do when you do get that CT sim coming from initial simulation is you need to make sure the body or external contour encompasses everything that you need to worry about in terms of avoiding collision. So here you can see on the left side, there's a ray station screenshot of the SDX device for a mediastinum patient and how the body encompasses everything that can be seen in that CT scan. And on the right is a very, very similar target done at NYPC with Eclipse. And you can see how the planner has gone ahead and encompassed the entire SDX device that they can see within this scan within the body, which is what defines the calculation model within Eclipse and ray station as well. So the point is that you want to make sure you're calculating an air gap correctly when you're treating something where you need to move the gantry head close to the patient when using a range shifter. And the concern is you're worried about the gantry colliding with the SDX sensor component. Okay, so here you can see also in the screenshots below, treatment planning CT has the SDX device cut off a little bit in the orange circle here, but when you have a reconstruction, you can see how tall the device is past the field of view. So beam selection is going to obviously depend on treatment site, and it generally follows your normal treatment planning guidelines that you would have. But if you are going to use a range shifter and you need to change the snout position to be closer to the patient, you have to account for this device. So the picture here on the left is, it's got a lot going on, but I think it's important. So you have the gantry in the upper picture, and it kind of shows you the isocenter laser with the green marking here, and how superior to this line, superior to the isocenter, there's 51 cm to the edge of the gantry head. And then below it's 33 cm, but really when you have an SDX patient, it's usually supine with the SDX toward in the head. So that's going to be worried about the 51 cm. So below there's a patient where the isocenter is kind of placed near the liver, and just a normal liver case, and how that distance between the liver isocenter to the SDX device is 35 cm. That is less than 51. So you have to be aware, if you're going to use anterior beams, that the device could very well come into contact with that gantry if you move it closer to the patient. Okay, so one way that we do it is it's called the snout approximation method. So we use this method to get the distance of the actual physical snout position distance, and we model it with its position on the patient's CT scan. So here I've measured, or kind of saw that it's 34 cm snout position, and I'm moving my measuring tool out to 34, doing an okay job here. And then what we do is we approximate the gantry kind of position for a single gantry position. So this one is for a certain gantry of 30, and I'm pulling out using the dose profile tool to kind of show what that gantry looks like on this CT scan, and blending the treatment planning scan, which is truncated, in the larger field of view as well. And so if you move up towards the SDX device on the larger field of view. You're going to see the elbows come into the field of view in the gantry, and you see there's a very good distance between where that snout position is and the device itself. So we use this method a lot, and we make sure that this allows us to have a sufficient air gap. Another method is to just add more air gap, making sure, per physics recommendation, just making sure that you have enough room to clear that sensor on the SDX device. Okay, so this slide just kind of summarizes it a little bit, how you can really see the snout approximation is clearing the gantry using the 34 cm distance from the isocenter and you have to do this for every gantry angle that you use. You can't just do one, definitely check them all. And then on the right side is a screenshot from RayStation and how the air gaps are listed. They're on the higher side. Usually I would say we would use around 10 cm air gap, but for these kinds of cases, you see them being a little larger. Okay, so next we're going to go into plan parameter selection. So everything is pretty similar to normal treatment planning. You would robustly optimize using normal site-specific parameters per your institution. Similar optimization parameters, beam computation settings, spot/layer spacing, and Monte Carlo dose calculation is preferred if you have it. Okay, but some specifics that we do take into account when using SDX is you want to have gating active. And what does this mean? So before we talked about how the beam synchronizes with your SDX device when you're using ProBeam. So if a patient falls out of the breath hold level, the machine automatically stops delivering dose and will resume when the patient returns to that breath hold level. In Eclipse, it's in the plan properties and it's called use gated, and you just have to make sure that's checked and on. In RayStation, it's a little different, where it's called motion synchronization. You just want to make sure that is checked and on. ProBeam only accepts this selection called gating with external marker, but you can name it anything you want. So we would, if you want to name it SDX, that's nice and simple for the dosimetrist to just make sure they have that clicked for their patients who are using SDX. Okay. And then in addition, we have some other things that we'd like to consider for these patients. So we can change the threshold for minimum MU post-processing in the dose calculation model. So normally for regular plans, you might use a 1.1 to 1.5 MU threshold, but for these patients, you might want to consider bumping that up to 3 MU or 5 MU threshold. On the right here, you can see that where the selection is made in RayStation, you can just change it to kind of any number you want. In Eclipse, it's a little different. You have to develop an entirely different calculation model to have a different post-processing, but you definitely want to consider doing this as a time-saving technique. In addition, we've mentioned before, you might want to limit your beam selection as much as possible. Ideally, no more than 2 to 3 beams, just really taking it so that it's efficient for the therapy team, for the patient, it's more comfortable. Definitely limiting it can help a lot. And the goal is to minimize the time it takes to deliver the plan on the machine. You want to help the patients successfully achieve it, especially if they're conventionally fractionated. It can be a lot to come in and have to do it every day. So we try to help them as much as possible in planning. Okay, so in the past at MPTC, we used an in-house program to estimate the delivery time for each field. And this helps a lot with knowing what to expect when it comes time to delivering your plan. So the output of this internal program gives you each time it takes to deliver each of the gantries that are chosen in the plan. So we were able to try for changing that minimum spot MU to something higher, 2, 3, or sometimes even more, and evaluate the plan quality, making sure that the plan is still as good as if we were using a smaller MU post-processing. And what we have here is a demonstration for one of a liver case where it was planned with 1 MU, a 2 MU, and a 3 MU post-processing. And you can really see how with the 1 MU, the maximum gantry time was 45.8 for one of the gantries, and the minimum was 36.6 seconds. But then when you move to 2 MU, it drops to 36.2 for the maximum time. And then when you use a 3 MU, it drops even more to 32.7 seconds. And that's roughly within the range of 30 seconds, which is our, determination of whether or not it's a SDX candidate. And then below in the bottom right, you really see the plan quality is still the same for the 3 plans. So what we would want to do is then use the 3 MU to have more efficient delivery and easier targeted for the patient. Okay, so on treatment monitoring, this is really important for proton patients in general. We do this through CBCT imaging and repeat CTs that are required at the baseline breath hold. This way we can establish that the treatment delivery is consistent with the plan. And then any clinical decisions that you need to make for replan or adjustments, we can do at that time. So here we have the original treatment plan on the left, and on the right is the evaluation CT, which was taken during treatment, and then forward count the plan onto that CT. And then below we have some recommendations. We can have recommendations for setup, and in this case we were saying maybe match more to the patient's surface, because it seems like that would allow for better coverage and maybe more OAR sparing, closer to what we were doing in the treatment plan. Okay, so now moving into the example cases. So at NYPC, you did see we have a pretty large number of patients that we have treated SDX using for our breast cases. So when we have a breath hold patient, the heart actually displaces from the normal free breathing positioning. The movement of the heart tends to be towards midline and then in the inferior direction. And the degree of this change is different from patient to patient. So we actually do take a free breathing and an SDX scan the same day, so that we can go ahead and make that comparison and make sure we're using the best plan for patients that are going to be getting breast treatment at NYPC. This is a coronal image, and you can see on the left is the free breathing position, and on the right is the SDX, and you can really see how the heart has been displaced relative to the other anatomy in the area. So for the same patient, you can see the metrics that we were able to achieve for this patient using SDX. We planned it with 2 gray times 25 for a total of 50. Very good coverage on the CTB. The esophagus mean is under 5 gray. The max is below 40. Heart mean is below 1 gray, which is really critical for our breast patients getting protons. Lung V20 is less than 20%. And the heart is the main OAR that generally demonstrates a dosimetric benefit with breath hold for breast cases. Okay, so the next case, I have a video, hopefully it plays. It's for a liver case getting SBRT 10 gray times 5, and as you scroll through, it's right on the diaphragm. So this patient is one of the highlights of wanting to get as minimal motion as possible within the patient, especially with the proximity that this case has close to the duodenum. And this is going to play again. You can, as it scrolls through, we can point out the duodenum is at the very inferior portion. So stopping the liver motion in this case is extremely helpful. And you can also see in this case, we have a lot of anterior beams. So I definitely used one of the methods of making sure that there is clearance for this case to the gantry and the sensor on the SDX. And all metrics are met really well. This plan came out really nice. So it's a good one. Okay, so the next case is a mediastinum and lymphoma. So the prescription is 2 gray times 15 for a total of 30. So kind of a low dose. but it's still really important to use SDX or at least consider using a breath hold treatment for these kinds of cases. Even though it's low dose, it's a very large volume that you're treating, and usually patients who are diagnosed with lymphoma and getting this type of treatment are on the younger side. So reducing the likelihood of getting secondary malignancies down the line is really, really important. So in this case, we have coverage is really good. And then we also took a look at the breast left and right mean. And in this case is very, very low. You can scroll and you can see how the entrance dose is just a little bit on the medial side of the breast, but not much at all. And then the lung V20 was also a concern, and it's under 20% for this case. And also we drew the thyroid, just making sure that it met clinical guidelines.
At the NPTC, we had 2 great patients. So the first one was a 72-year-old male, and the target was abdominal mass. That was our first SDX patient, and a great patient. So what we do in the grid, we have a 15 gray before the normal fractionation. So this is part of the spatially fractionated radiation therapy. For this case, we use 90-degree gantry angle, and then because we didn't use range shifter because we had enough depth, so the snot was at 42 cm, fully retracted, and the delivery time was about 55 seconds, and patient was able to hold the breath hold, did the breath hold in one time, and then we delivered the plan in 1 breath hold. So this is the dosimetric parameters. So for 15 gray, so we had a good coverage or like good dose to our virtual target or cylinders here in the target. And we were able to spare OAR. So the maximum dose we had to the spleen was about 1.4 gray, and the rest was less than a gray. The second patient with SDX with grid was a small part of the liver. For this case, we used a 0 gantry angle because the depth was not enough, so we had to use a 2 cm brain shifter. So for that one, we had the snot position at 12.3, and it gave us air gap of about 7.5 cm. Again, the delivery time was less than 50 seconds, and patient hold the breath during the delivery, and then we treat the patient with 1 breath hold. And again, these are the dosimetric parameters. So the dose to the average dose to the cylinder was about 14.5 gray, and there was a minimal dose to the stomach, large bowel, and heart. Regarding that patient, so this is the effect of air gap. So on the top, you see the air gap with a 7.5 cm. So as you see a really good grid pattern here. But if you have a larger air gap because the spots are getting larger, so then you will see that the 30% isodose lines are getting merged here. So and also your dose cloud is getting bigger. So then you have a bit more dose to the normal tissue surrounding to the target. But doing this, as Julie said, you need to look at the collision. So what we did, we kind of simulate the treatment. We had the kind of phantom, and we put the SDX and make sure that like that 7.5 cm air gap or like 12 cm snot position is good, and it's not having, we don't get any problem with the collision as we wanted to the treatment.
Okay, so just summarizing some of the challenges that might come up during treatment planning with SDX patients. The treatment delivery time can slightly increase when using the SDX, which can be cumbersome for the patient. It may result in a replan if the patient is unable to stay consistent throughout the treatment course. So identifying them ahead of time as good candidates and asking them to practice is really important. And of course, it definitely depends on the target volume and just the baseline ability to hold the breath hold. If a range shifter is needed for treatment planning for a superficial tumor, the SDX can result in larger air gaps and increasing the spot size, it can make planning a little more challenging for some cases. Also, lastly, using range shifters may result in a collision if not careful due to the need for increased air gaps for anterior fits. In summary, Include the SDX components seen in your treatment planning CT into the body/external. Gantry is very large inside. Check for those collisions when you're moving that snout closer to the patient. Either you can use the snout approximation method or just use larger air gaps in general. Choose the correct use gated or motion synchronization checked on selections in Eclipse and Ray Station treatment planning systems respectively. Consider the saving time techniques that we have to improve treatment delivery and efficiency. You can increase the MU threshold for minimum post-processing spot MUs and limit the number of beams as much as possible for your cases. Many different clinical scenarios, as you've seen, just a handful can benefit from this technique, breath hold using SDX.
And the last part, maybe in the 5 minutes, I'm going to look at some dosimetric evaluation of breath hold plans. So the first part is like looking at the breath hold versus non-breath hold, and then I look at the reproducibility of the breath hold plans. So as I said, the breath hold technique, we use it to minimize target margin, and we can spare the normal tissue. Initially, when we started with SDX, we had only one SDX system in one of our rooms. We have 4 gantry rooms. So because we were not really experienced with SDX at that time, and we were not sure, like, if we get a CX problem or treatment room problem, if we can proceed with the treatment. So we decided to have a backup plan, a 4D CT backup plan. Then later we bought another SDX device, and there was a much more improvement in the software. So we were more comfortable. So we stopped doing the backup plan until the 2019 with COVID. We again decided to have a backup plan if the patient comes with a symptom. So we go with the backup plan and not using the SDX. So in this part, I'm going to look at the compare the breath hold plans versus non-breath hold plans for about 77 patients and look at the kind of the benefit of using the breath hold plans. So we look at the 77 patients, so different treatment sites, mainly liver and mediastinum and lung, and then for all of them we use the 75% of the DYBH as a breath hold level. And we'll look at the breath hold plan versus a non-breath hold plan. So our dosimetrists, they created both plans clinically acceptable for treatment. And to do the analysis, I look at the DVH parameters, the mean dose to some of the OARs and the maximum dose to small bowel, large bowel, heart, and spinal cord. The first one is look at the target volume. So the blue is the breath hold plan. The red is the ITV from the non-breath hold plan or 4D CT. So as you see, is about 25 to 30% reduction of the target volume. So that's how we can spare OAR, because we make the dose cloud smaller. So the main benefit is like reduction in the target volume. And then we look at the maximum dose to the small bowel and large bowel, heart and spinal cord. As again, you see there's a variation between like 16% to 32% reduction in the maximum dose to the surrounding OARs. And if we look at the lung and liver, so they're more affected by breathing. So again, we see the same thing. So it's about 25% reduction to the dose to the lung. So the lung V20 dropped by 25%, and for the liver mean dose, it dropped by 24%. The last one, look at the mean dose to other OARs, stomach, kidney, esophagus, and heart. Again, we have about like 20 to 30% reduction in the dose to these OARs. One of the reason we use the breath hold, we want to minimize the target margin. So by doing that, so you make the dose cloud smaller. So now you need to kind of monitor that, like, your plan is still valid for the treatment. So the way we do it, we look at the QACT. One is like to look at the tumor response or any change in the anatomy. Also, we want to look at the reproducibility of SDX plan. So We use the 5-minute robust evaluation and also optimization. So for this case, we look at the 30 patients, and then we look at the total of 62 QACTs. For each patient, we had 1 to 3 QACTs, and mainly we had the liver and mediastinum and lung, and then there are some cases of abdomen, pancreas, and esophagus. And we look at the kind of like evaluate the QACT by copying the plan and recalculating the plan on the QACT and just look at the dosimetric parameters. At our center, when we have a coverage, the V95 dropped by 5% usually, we consider doing the replan, or we have a kind of significant dose to organ at risk. Then we look at the DVH parameters for QACT plans, and then we look at the errors as like a percent difference for the target and absolute dose for the normal tissue. And then we report the error window, which is covers the 95% percentile. On the left, there's the change in the volume for CTV1 and CTV2, which is the boost plan. So on average, the error window is about 8.6% for CTV1. For CTV2 is about 4.5%. The mean is about 0.1% for both of them. If you look at the coverage, V95 and D95 and mean dose, you see a small variation, so it's about less than 5%. And if you look at the maximum dose and minimum dose, because as a larger variation, because you look at the point dose, so you see like for maximum dose, the error window is about 5.7%, and for minimum dose is about 18%. If looking at the OAR, so the mean dose to heart, esophagus, stomach, and kidney, all of them were within the 2 gray change. And the maximum dose has larger variation. So small bowel and large bowel is less than 3 gray change. Heart and spinal cord is about a 5 gray change, and with the error window. On average, they are like within like a half a gray to 1 gray. Look at the liver and lung, they're more affected by motion. So again, we have a small error window about a gray for the liver mean dose, and then for a lung V20 about 3.2%. Out of those 30 patients, we had 4 replans, and most of them due to the change in the anatomy. In conclusion, we can use breath hold plans to kind of reduce the target volume. So we saw that about like 20 to 25% reduction in the target volume. And also we can spare the OARs for lung and liver. We saw about 20-25% dose reduction. Similarly for other OARs, we saw that like for mean dose to OARs about 20 to 30%. And larger variation for maximum dose within 15 to 35%. Regarding the reproducibility, if there's no anatomical change, usually using the robust optimization and 5mm, and it depends on the target location, range uncertainty consideration, that we get the fairly robust plans for breath hold plans, and that helps us to have a good plan during the course of the treatment.
Okay, so we just want to thank everyone. We want to thank fellow physicists, dosimetrists, doctors, and therapists, and also a clinical programmer at both MPTC and NYPC. It's been a lot of fun getting to work with SDX and getting to work with our patients, delivering the best care. So thank you to everyone that we work with.
Julie, there were a couple of questions in the chat box if you want to read through those. One talks about delivery time, and then the other talks about your average appointment time for patients that are using SDX system. So if you want to look at those questions and give those an answer, I think everyone would appreciate it.
Sure, let me just pull up the first one. Okay, so I did answer the mask one as we were going along. Yeah, you have to cut a hole in the mask in order to incorporate the SDX device for patients who are in the mask. let's see, does delivery time include if they are a good or bad breath holder? So at least at NYPC, we really have a threshold cutoff where we only allow patients who can really reach that 30 to 35 second breath hold onto the machine for breath hold treatment. Sina, do you have a similar
Same for NPTC. When we do the training, the goal is we start with the 20 seconds, and during the training phase, we want a patient to get to 30 to 35 seconds. And if patient cannot do that, we consider go to 40 CT.
Okay, the next one is, what is the average treatment appointment length for your SDX patients? That's a good question. I think it's an hour. I can't be totally sure about that. It might be 45 minutes to an hour. And I think once we get the patient going in the first couple of treatments, we modify that appointment schedule. If they're faster or slower, we modify it as we go. What's your experience, Sina?
Yeah, so we usually start with 1 hour, same as NYPC, and then it depends on the patient target size. So it can be like half an hour or like less. Usually, most of the patient, they finish in the normal kind of like the same as other treatment in 30 minutes. So it's all depends on the patient and the target size.
The next question is the program that you created in planning. I think that might be related. I forget which program they might be referring to. But we use Eclipse, and Sina uses RayStation at NPTC, and any in-house programs that we do create can be used, I think, in both. We create programs outside and access them through Eclipse. How about at NPTC? Do you have RayStation specific programs that you use?
Most of the scripting we do in RayStation, and then even for that treatment time estimation, we use RayStation to kind of do that. Also, you can use it like ours, what we started with in-house program. So basically we exported the plan, DICOM plan, to a MATLAB code and or Python code, and then just run that one and get the full delivery time.
Okay, so this might be a clarifier. Does the SDX program time out if the patient is in a regular breather? Timeout. I'm not sure.
Yeah, so in some cases, if the patient is slow breathing and it's kind of like, and it takes more time to go back to the breath hold level, so it, SDX can time out, and then depends on the setting. So you can reset the software and then start over. So basically, you can do it again, and then there shouldn't be a problem after that.
And there was one other question that came in the Q&A box, and it was, how many patients on average do you treat daily that use the SDX system or use breath hold?
That's a really good question. And I think the answer is it fluctuates a lot. I know a couple of weeks ago, we treated like 8 to 9 patients with SDX, but that's on the high side. So I would say probably like a handful, maybe 4 to 5 on average, maybe even less. It just really depends on the patients that are coming through and who really needs it. So it fluctuates a lot.
So I think that is the end of our questions. And I do want to thank Julie and Sina, and I want to thank Annabelle and Michelle from DYN'R for working with us on this webinar. For those of you that are looking for MDCB credit, this was approved for 1 CE credit. You'll receive an email in a few days with a link to this recording, and then there will be a short quiz or survey that you need to take, and then you'll receive a certificate. Also, Annabelle and I will send in that list that to the MDCB so that it'll show up in your wallet or however they keep those there at MDCB. So it'll show up in your account. But if you want that certificate, or if you need that number earlier, you can access that as soon as we get that recording sent out to you and you do the survey or the quiz. So if you have any questions about that, you can either email me or you can email Annabelle. You could get a hold of Julie and Sina, and they could direct you to us if you have questions about that CE credit. But again, I want to thank everybody that was on this webinar. especially to Julie and Sina for taking time to put this together and then do the presentation. And I want to invite you all to stay tuned. We have other webinars scheduled with DYN'R and with other vendors as we continue to try to give back to the profession and try to just give you opportunities to learn things that you may not have had the opportunity to do so far. So thanks a bunch, and I hope to see you all at AAMD.
Thank you, Cheryl. Thank you, everyone.
Bye, everyone.
Bye, everyone.